Hi, good morning all. Let us discuss about Abruptio placenta today. Definition is it is premature separation of the normally implanted placenta from the uterine wall after 20 weeks of gestation until second stage of labor. So here is the attached placenta left side of the diagram and right side it is detached placenta from the uterine wall. And epidemiology, 1/3 of all antepartum bleeding is due to abruption placenta, and incidence ranges from 1 in 75 to 1 in 225 births, and recurrence is 5 to 17% after one previous episode and up to 25% after two previous episodes. So etiology is primary cause is uncertain and several associated factors are identified as follows. Increase in age and parity, preeclampsia, chronic hypertension, preterm ruptured membranes, multifetal gestation, cigarette smoking, cocaine abuse, previous history of abruption, uterine fibroids, hydramnios. It is classified as revealed type, concealed type and mixed type. And in revealed type, bleeding is revealed, and concealed type there will not be any obvious bleeding, and it is mixed. It is both combination of revealed and concealed. Concealed type, it is 20%. Hemorrhage is confined within the cavity and detachment of placenta may be complete and complications are often severe. Revealed type, which is most common, comprises of 80%. Here blood drains through the cervix, placental detachment is more likely to be incomplete and complications are fewer and less severe. So here there is external bleeding in abruption. So left side figure, it is normal placenta, and middle one there is abruption, collection of blood behind the placenta, and the third picture is placenta previa, that is centrally located placenta. Coming to pathophysiology, which is initiated by hemorrhage into the decidua basalis leading to hematoma formation, and in concealed type blood accumulates and seeps into the myometrium, thereby formation of covular uterus. And what is covular uterus? It is also called as uteroplacental apoplexy. It was first described by Kovaler in early 1900s. Here there will be extravasation of blood into the uterine musculature and beneath the uterine serosa. It is demonstrated only after laparotomy. So these myometrial hemorrhage interfere with the uterine contraction leading to postpartum hemorrhage. So this is the covular uterus. And pathophysiology behind it is blood gains access into the amniotic fluid through the ruptured membranes. With disrupted placental site, there will be decreased metabolic exchange leading to fetal hypoxia. At the same time, this process, if continued with release of tissue thromboplastin in maternal circulation, it leads to disseminated intravascular coagulation. And complications of abruption are divided into maternal and fetal. Maternal complications are maternal mortality, hypovolemic shock, renal failure, DIC, PPH, resensitization, and complications of massive transfusion. Fetal complications are fetal death, hypoxic brain injury, IUGR, neonatal anemia, congenital malformations. Clinical features, patient presents with vaginal bleeding, uterine tenderness, back pain, fetal distress, hypertonicity, and fetal demise. How to diagnose this? Basically from the history and physical examination, and there will be triad of external bleeding through the cervical os, uterine pain or back pain and fetal distress should be of high suspicion. Don't do digital cervical examination until placenta previa or vasa previa are ruled out. Ultrasound is of limited value, but for large abruptions there will be hypoechoic areas seen underlying the placenta. So here is the ultrasound picture, fetus, and above it is placenta and above it is retroplacental clot. So this is the intra-op finding. There is a big retroplacental clot. And laboratory tests we do routinely are CBC, blood grouping and typing, urine analysis, liver function test, renal function test, prothrombin time, APTT, fibrinogen levels, and fibrin degradation products. So classification of abruption based on history and investigations, it is divided into grade 0, 1, 2 and 3. 0 is asymptomatic and only incidental finding of retroplacental clot during laparotomy. Grade 1 is vaginal bleeding will be there but no maternal or fetal compromise and uterine tenderness might be present. And grade 2 is fetal distress but there is no evidence of maternal shock. Vaginal bleeding may not be present. And grade 3, maternal shock and fetal demise will be there. Marked uterine tetany and atony and tenderness will be there. Vaginal bleeding may not be present. And how to manage? If it is term gestation and patient is hemodynamically stable, plan for vaginal delivery with cesarean section done for only other obstetric indications. Follow serial hematocrit and coagulation studies and continuous fetal monitoring to be done. But if the patient is hemodynamically unstable, start aggressive fluid resuscitation, transfuse packed RBC, fresh frozen plasma and platelets as needed. Maintain fibrinogen level more than 150 mg per deciliter, hematocrit more than 25% and platelet above 60,000 per microliter. Urgent cesarean section is needed unless vaginal delivery is imminent. So to conclude, abruption is an important cause of fetal and maternal morbidity and mortality. Etiology is poorly understood. Various management options are however available. The principle of initial assessment of the patient's condition and subsequent planned management aimed at resuscitation and prolongation of pregnancy if possible, or immediate delivery either for fetal or maternal indications. Thank you.